Thank you, Kirsten, Ben, and Ted. We've been talking a lot recently about the new conditions of participation rule, and maybe a good point in the program to just revisit a little bit about our partnership with PatientPing, which, as Ben said in the presentation, began in mid 2018. It has been a great partnership. We were looking for a partner who could help us deliver real-time notifications and the care coordination functionality that could wrap around that. And as Ben said, it's been a really good natural marriage of two organizations. Just a little bit about how it works. All of the ADT traffic that runs through our network, those are the admit, discharge, transfer messages that every participant is sharing with us, essentially is shared with PatientPing, and those are what inform the notifications that PatientPing makes available to its clients. So that's kind of the technical foundation. And with respect to the new rule about Medicare conditions of participation, that really means that organizations, hospitals that are participating in WISHN are already a good distance down the road toward compliance, right? They're feeding their ADT data into the WISHN/PatientPing environment, and that's foundational for compliance with this new rule. Obviously, PatientPing takes it that last mile and ensures that the notifications go out and wraps around that that audit functionality where organizations can lean on PatientPing to give them the data they need in the event of an audit of their compliance. So it's been a great partnership. We've really enjoyed working with them. You've already heard this morning from Sarah Morgan and Dr. Thrasher about the extra layer of functionality and benefit that PatientPing brings to the client WISHN relationship. So we look forward to that continuing, and we would highly recommend, if you haven't considered working with PatientPing, that you take a look at it, certainly with respect to the conditions of participation rule, but in general. So we're looking for questions. Are there any questions, Steve?
Yeah, we're waiting on some questions from Ted Barbeau, PatientPing's colleague. So while we're waiting on that, maybe if Kirsten or Ben, there's additional information, color commentary that you'd like to add to your presentation while those questions are coming in.
Yeah, Kirsten, I'll give you a chance if there's anything on the rule you'd like to touch on.
In general, I think the presentation was fairly comprehensive in terms of the requirements. One question that we have gotten from some folks is what hospitals are actually going to be subject to this, because the rule just does label it at the condition of participation level at hospitals, critical access hospitals, and psych hospitals. But within that hospitals bucket, that also includes inpatient rehab facilities. It includes short-term acute care hospitals, long-term care hospitals, as well as children's and cancer hospitals. So that's a common question we've had in terms of the rule clarification. But happy, obviously, to address any other specific rule questions that come through the audience. I don't know if there's anything you want to elaborate on in terms of our solution, Ben.
Well, one thing that comes... Go ahead, Ben.
Yeah, I was going to say, the thing I'll touch on is, as Joe mentioned, the ADT feeds that we're collecting already. I've had some questions from some folks in Wisconsin around, are those sufficient, or do we need to do anything else? And the easy answer there is we would do a quick check-in on what information is coming through on that ADT feed now, especially for the direct message component, making sure we have the proper NPI information is really where we would start. So it's really a very simple process. As Joe mentioned, you're already well along the way of being prepared. So that is something I did just want to touch on, but I'll turn it back over to Joe for your question.
Yeah, I was just going to say we're roughly 7 weeks away from the May 1st compliance deadline, and just kind of a practical question. if somebody was to reach out to you today, are they going to be ready to go by May 1st?
Yeah, that's a real good question. It depends. ADT feed, what information we still need. We're actually, it looks like 51 days away right now. We have on our website, so that time is going to come up very quickly. An organization should be thinking about, do you need to contract with a new organization? If you're already a PatientPing customer, that's very simple. If you're not a PatientPing customer, then there's a little bit of contracting you need to worry about. If this is something you're thinking about building on your own, that's something else that you have to look at. What's the time involvement on being able to have something in place to ingest rosters from organizations, send data real time to organizations, including post-acute facilities, which can be a challenge. So the time is really now to be acting. We have the staff and the availability on hand to move quickly. And so we are seeing hospitals sign up on a daily basis right now with still time to get ready. But really the time to act is now.
And the daunting part of it, one of the daunting parts of it is the requirement that it has to be nationwide. And you're going to have to look to somebody with a nationwide network like PatientPing to solve that problem. So we think it's a great solution, and we would certainly encourage folks who haven't thought that through. There's a little time, but there's not much time. And compliance with Medicare terms of participation is really not optional. I don't know of any hospital that really doesn't deal with Medicare. So it's obviously very important. And again, we encourage our clients who are still looking for that solution to get in touch with our friends at Ping.
And there's one thing you mentioned, Joe, that I'll touch on is you mentioned that nationwide network. There was a call we did recently with some members of CMS, and there was an example brought up around a patient who might be a snowbird patient, say in Florida, spends half their time of the year up north. If that patient's part of an ACO down in Florida but has an event while they're spending time in Wisconsin, shows up at a Wisconsin hospital, that Florida ACO will definitely want to know what's going on with their patient. They'll want to coordinate care. They'll want to work on their quality improvement activities. And so they will definitely want that information. So that's where that nationwide or ability to send those notifications across geographies is very important, and making sure it's across the different technologies as well, knowing that not every EHR vendor is the same, knowing that EHRs in the post-acute are vastly different as well. There's a lot of nuances to the rule that really, really do require folks to make sure they're fully covered.
So a couple questions that we do have coming in. One is actually two are nicely aligned. So I'll ask in a way that addresses both. Hospital is currently sending ADT's tuition, which gets to PatientPing. First, does that cover the hospital's requirement for the notification rule or the COP? And understanding that some EHRs are implementing technical solutions and functionality to manage and send notifications via direct messaging. And those there's additional information that's being sent to tuition in the form of CCDAs. So the question is, can PatientPing accommodate these direct message interface transmissions?
Kirsten, do you want to take that one?
Sure. So yes, we can facilitate and take in and send direct messages on behalf of our customers. So that's the enhancement we're just going to need to make sure as part of the ADT feed sent tuition today, if you send your ADT feed tuition. So we just want to make sure that identified provider MPI is included in that HL7 feed sent to us. And then we'll be able to send direct message notifications using the direct protocol to any of those identified providers when we match that MPI to the Direct Trust National Aggregate Directory of Digital Contact Information for Providers. Now, some EHRs have the ability to send direct messages. One of the things that's been a challenge for a lot of organizations when they're thinking about applying existing direct messaging infrastructure is that adoption of direct messaging isn't very uniform or very comprehensive among some of the required recipient categories, like especially in the post-acute space. So there's very uneven adoption of direct messaging for those particular required recipients. So if you just are relying on the direct messaging piece, there will be some gaps potentially for hospitals looking to be able to send notifications at scale to those post-acute providers and to those primary care entities that may not even have direct addresses. I don't know if Ben, you wanted to add anything to that.
Yeah, and along with the post-acute, the rule's pretty specific about calling out treatment, care coordination, and quality improvement initiatives. So using an example from several of the ACOs in Wisconsin right now, there are care coordinators working on behalf of the providers that roll into that ACO, doing the care coordination and quality improvement work. And those folks would need those direct messages as well, but they may not even have a direct message address. So that's where leaving this rule to direct message alone does show some gaps that could make it difficult to remain in compliance.
Another question that we're seeing come through is reasonable effort. So is sending data already to Wishin, to Commonwealth, through the EHR, or in addition to the information that's available, is that enough? What is the extent of reasonable effort, and what might be some short-sightedness to that?
Sure, I can take that one. So CMS mentions the phrase reasonable effort in the final regulations to say that hospitals must make a reasonable effort to send notifications to patients' established primary care practitioners, their established primary care practice groups and entities, applicable post-acute providers, as well as any other provider identified by the patient as being primarily responsible for his or her care. So they never define reasonable effort in the regulation. One of the things that we have taken in development of our compliance solution is that we believe reasonable effort is sending notifications to all 4 of those required recipient types. And so we think that hospitals will need the policies, procedures, and systems to ensure that they are sending those notifications in real time to all 4 of those different provider types. And having documentation to prove that they have tried to send those notifications. So really what we've tried to do is provide functionality to ensure that the hospital is set up with the infrastructure to send notifications to any patient-identified providers, whether that be the PCP that's recorded at registration or any other provider that the patient mentions as someone that they want to receive notification of their care event, as well as those providers out in the community in the post-acute or ACO or FQHC setting that can't be reached with the direct infrastructure set up today.
Ben, anything else to add to that?
No, that was great.
Another question is, as the data is submitted to Wishin without informed consent from the patient, is there an obligation on the providers to receive consent from the patients to comply with this COP?
I can take that again. So no. So you can. It's explicitly mentioned in the rule text that information sharing under this condition of participation fits into the same treatment TPO exception to HIPAA that you guys use today to send notifications to providers in the community through PatientPing, through data that comes to us through Wishin. So there's no extra consent obligation for hospitals, but it is clear that you need to be sending data in compliance with existing. It doesn't supersede existing state and federal regulations as it pertains to information sharing, but there's no consent required to send notifications. It fits under that same exception to HIPAA.
Great. So I'd like to extend from Dr. Thrasher's presentation and a question that came in regarding PatientPing functioning in the psychiatric setting. Ben, knowing that you've been working with Behavioral Health Division, could you elaborate on how PatientPing is functioning in that setting and providing value to those care coordinators and to those that are providing direct care in that setting?
Yeah, happy to touch on that. And I think Dr. Thrallon kind of setting the table for that. And the use cases, the actual delivery of PatientPing really isn't that much different than how ACOs, federally qualified health centers, anybody else managing vulnerable patient populations are using PatientPing today. So if you have a vulnerable patient population and you're worried about patient engagement, you're worried about the cost of the patient, the quality metrics involved with caring for that patient, any of those items, real-time information is crucial to be able to engage and work with that patient to reduce cost and improve quality. And with the behavioral health team, they have had groups of patients where they know these patients are accessing healthcare outside of their four walls. In order for them to properly engage that patient, be part of that patient's discharge plan, they needed that information in real time. And so the network we get through our partnership with Wishin allows us to have all those ADT feeds already gathered. The Behavioral Health Division sends us a roster of patients that they want to monitor, and then we layer that roster of patients across those live ADT feeds that are taking place at all times. So it allows them to know for sure that their patient is right now at, let's say, an Aurora hospital. And they can reach out to that Aurora Hospital ED team, just like Dr. Thrasher was mentioning, and coordinate care for that patient that's in the ED right now. And that's a whole different level of service that these patients have never had access to before because those care managers have not had access. So we went live with behavioral health. I want to say it was May, June of last year. And there's been a couple programs already added to that. So it's been a success from our end. And we just love being able to provide the ability for them to do new things for their patients they haven't had the access to do before.
We don't have any other questions specific to this presentation. Joe, is there anything else you'd like to add?
Well, just again, great partner for Wishin, and I think we've heard a couple of different examples today of where they bring that extra layer of value to the questions around interoperability and sharing clinical data in a timely way. So thanks again.